Yes, good afternoon, everyone. Hopefully everyone can see that on the screen now. Got it loaded up. Thank you for joining us for this month's webinar. As Les said, enhancing postural care through effective engagement. So over the next 30 minutes or so, we'll share insights, strategies, and hopefully some practical guidance as well for those of you working within postural care, especially if you're working with individuals who may have complex needs, cognitive changes, or communication challenges. Hopefully by the end of the session, you'll be able to recognise how individuals with complex needs are at an increased risk of body shape distortion and why early, sound, accurate assessment is critical in preventing secondary complications. Understand that physical and neurological impairments alone do not explain poor postural outcomes, so cognitive and communication barriers are often the primary challenges in delivering this effective postural care that we want to implement and can actually delay intervention or even distort our understanding of the person's needs. Hopefully be able to identify reasonable adjustments that can improve engagement and build that rapport, build our therapeutic relationships and the accuracy of our postural assessments for individuals with cognitive or communicative differences, to make a difference in the safety, I guess, of the decisions that we make together. And finally, I want you to leave with at least one or two practical strategies that you can apply right away into your own clinical practice to be able to gather meaningful information in that assessment process that enables safer, more person-centred and clinically effective seating provision and overall postural care. We won't be covering objective assessment techniques, things like hands-on postural assessments, measurement tools, the technical elements of equipment prescription. Those are practical skills best explored in a face-to-face, hands-on environment. And as Les said, we do offer kind of dedicated training events virtually and face-to-face to cover that in a bit more depth. But what we will cover today is how to get the most out of every touch point. Whether that's in kind of the planning stages, over the phone, or then face-to-face when we get hands-on, by building trust, being able to adapt your approach and really tuning into the person in front of you. Because gathering meaningful baseline data doesn't start with just a measuring tape, it starts with that connection and that engagement. Specialist seating provision, and I guess more broadly postural care, relies on us being able to define clear clinical objectives that lead to compliance and comfort and meaningful change. So that's where effective engagement becomes essential, not just as a soft skill, but a foundation for safe and effective provision. Let's set the scene first of all. There are approximately 16 million people in the UK with a disability, with an estimated 1.2 million who use a wheelchair. 1 in 10 individuals with a disability are described as having complex needs. That's around 1.6 million. And that's, of course, estimated to grow to 2 million within kind of the next 3 years. Within that population, it's estimated, it's a difficult figure to pinpoint, but it's estimated there are around 75,000 present with profound and multiple disabilities, which, as we know, has grown significantly over the last 10 years due to advancements in things like medicine and technology. Complex disability goes just beyond intellectual disability and can also include things like individuals on the autism spectrum disorder, mental illness, delirium, those diagnosed with dementia, and even some of those sensory impairments that can challenge the perception of the outside world. Well-being and complex needs are intrinsically linked. Because complex disabilities does present unique challenges and obstacles in daily life, and support is needed for that individual to be able to engage, to communicate, to be able to develop new skills and live more independently. Now, there are a number of factors that predispose this population of individuals to developing postural health concerns. We know that people with complex needs, particularly those who are non-ambulant or have significant motor impairments, are at a high risk of developing body shape distortion, which can lead to those secondary complications like pain, respiratory compromise, digestive issues, and even reduced life expectancy. That combination of inactivity, spending longer in one position, asymmetrical movement patterns, and then the compounding effects of gravity leads to this high risk of body shape distortion. But what's often overlooked, especially within this client group, is that one of the biggest barriers to early, timely, effective intervention isn't necessarily those obvious physical impairments. It's cognitive and it's communicative. If someone can't clearly express discomfort, or if the clinician or the therapist can't confidently interpret that discomfort, then we may miss early signs of asymmetry or poor positioning, which then we know leads us into this vicious cycle. There could be barriers to interaction, then having that limited engagement during our interventions with them, and sadly delayed or incomplete postural care input, which further compounds the risks to the person's health and well-being. So hopefully today's session is about exploring how we can bridge that gap, making assessments more person-centred, more responsive, and ultimately more effective in protecting body shape and well-being. Effective 24-hour postural care plays a critical role in mitigating some of those health and social care risks, so reducing or minimising the chance of avoidable harm, such as things like infection, respiratory infection, pneumonia, developing other illnesses, digestion concerns, constipation, injuries, pressure injuries, falls injuries, the hospital admissions that can come with these issues, and sadly even premature death. So there's a really kind of strong but equally heartbreaking report that comes out. It's the Learning from Lives and Deaths programme that looks into adults with a learning disability. And the most recent one that was published from data from kind of 2023 showed that adults with a learning disability die on average 19.5 years sooner than people in the general population. That's almost 20 years of their lives lost from something that could be avoidable. What this programme shows is that we need to consider these potential complex disabilities as a high-risk group, especially from deaths from things like respiratory compromise or respiratory disease, especially things like pneumonia, which we know is impacted by somebody's positioning and their ability to be able to sit upright and to be able to open the shoulder girdle. There's also a confidential inquiry as well, the SIPOL programme that kind of looks into premature death again. There's this link being established between failure to protect body shape and resultant premature death. And a key issue really that's identified is this inattention to predicting potential problems, hence the need for us to be proactive and not reactive. But we can't do that without first finding out all the data that we need to make informed decisions. So sometimes we have to be detectives, we have to stop making assumptions and really interact with the person sat in front of us, regardless of how complex their needs may first appear. I guess it's why we become therapists, why we become clinicians, right? To make meaningful change, to care for individuals, to support them through that healing process as best possible. But then we have this therapeutic challenge that can sometimes be a barrier for that. I know we have kind of a range of clinicians from different specialties joining us for this session, but the majority of time what we see is that responsibility for postural care, for equipment provision outside of specialist services tends to fall on community therapists, on social care, on NHS community, potentially occupational therapists. And often they receive this postural or seating referral without really a full clinical history. Maybe they've been lost to services for many years because they don't fall within the defined category. The individual may then have alternative communication, cognitive impairments, or even be neurodivergent. Time pressures then, resource constraints that we know are happening, and the complexity of multiple needs can make it challenging to carry out robust assessments. We know kind of realistically that this happens, especially if that therapist hasn't been supported through specialist training or hasn't had much exposure to individuals with complex needs. So all those factors together can lead to fears, potentially, about doing the wrong thing, potentially making decisions based on incomplete data, which may then, of course, compromise outcomes. My aim here today is to hopefully give you some tools and perspectives to reduce that risk and increase your autonomy and your confidence. So I'm going to make this solution sound very simple, and in a way it is, because no matter how complex the equipment, how technical the positioning, or how urgent the referral, we are first and foremost working with people. Every individual, as we know, brings their own way of engaging with the world, and our job as clinicians, as therapists, is to meet them where they are, not expect them to fit into standardised processes. And that's essentially what personalised care is. Whether someone has limited verbal communication, whether they have cognitive or neurological impairments or sensory differences, we need to remember that it's not a diagnosis, it's not a checklist, that they are a person. And when we start there, that's when we truly see them as individuals. And it means we can create this space for meaningful engagement. It means we get better assessments done, and ultimately we can have more effective postural care and ultimately achieve our clinical objectives. We can use a biopsychosocial model to guide us through that, to help us consider all those elements of a person's health and well-being and how these may be interlinked. So you have, of course, to have the physiological pathology, potentially the diagnosis, the prognosis, the relevant past medical history, any current issues or concerns to be mindful of. There's the psychological elements, you know, their thoughts, their emotions, their behaviours, and how that might impact on their engagement. But then also the socioeconomic, socio-environmental, cultural factors as well, thinking about their occupation, their hobbies, their families and their support network, and even their finances, because we know that does play a part in things like funding justifications. That holistic approach is what ensures that person-centred care, that personalised care approach. So not a narrow focus on the diagnosis, but the consideration of the person's well-being. So by determining key information about the individual and potentially their support network, especially within complex needs where we do rely quite heavily on that, will not only ensure the appropriate provision and the strategies that are employed, but it'll make sure that anything we do put in place is safe and consistent as well, and we get that ongoing compliance. We just need to make sure that any strategies or interventions or equipment that we put in place is compatible with daily life. Because as I said, that's ultimately how we achieve our clinical objectives alongside the individual and support network and their needs and preferences. Individuals and their caregivers do report higher levels of satisfaction when we consider kind of the biopsychosocial model and involve them and integrate them in that way, which, as we know, can help everyone then make informed decisions about things like seating provision or broader postural care to ensure that we get that consistent compliance. It's about reducing dependency, reducing the effort, reducing the risks, but ultimately thinking about daily life, making it compatible so that anything we put in place enhances rather than restricts them. So the ultimate goal really of everything we're talking about today is, I mentioned it a few times, about compliance. If an intervention or a strategy or a piece of equipment isn't used consistently, we simply won't achieve the outcomes that we intended, whether that's postural alignment, pressure care, function or comfort. That compliance doesn't just depend on the fit of the equipment or the compatibility of that intervention. It actually depends on how it fits into the person's life. That's why it's really key, as I said, to understand what daily life looks like. What does that piece of equipment or intervention need to offer them to make sure that they use it consistently? And that's why we need to think holistically about things. So we've got personalised care, making sure that the provision reflects the individual's abilities, their preferences, their goals, If the person can't tolerate it or doesn't feel safe, then they simply won't use it. Then we consider the support network where possible. Who's helping the person day to day? Do they understand the purpose of the intervention? Do they understand the risks and the safety aspects of that? Are they confident in implementing it? And do they feel it meets the person's needs, considering that they might know the person quite well? Then we apply our clinical judgment and our reasoning, our baseline measure, our objective data, those interactions and engagements that we have with people coming together to inform the prescription or the provision. And of course, thinking about evidence-based practice and that, if that's something that you need support with, if you're struggling to maybe find the right evidence or guidelines or legislation, let us know, and hopefully we can point you in the right direction. And then finally, we do need to be honest about service provision as well, considering the climate now. What is available? What can be delivered consistently? How do we protect funding and resources? So thinking about quality, reliability, the longevity of equipment that we might put in place. And when all of these things align, so support, personalisation, our reasoning and provision, we create this solution that's not just clinically sound, but it's actually implemented, and that's when we see meaningful, lasting outcomes. So let's now try and link this theory to our clinical practice. I like to think of postural assessment or intervention. It's 3 distinct phases, but they obviously are interlinked: the before, the during, and the after. So before, this is, I guess, a really important point when we talk about subjective assessment, history taking, gathering background information, understanding communication needs and preferences, making an effort to establish that trust, and developing that into ensuring things like reasonable adjustments are made to maximise our point of contact. Then, of course, we have the during, the assessment or that touch point with them, that face-to-face opportunity. And alongside our clinical skills, it's about considering our own communication style and our own approach, observing closely, pausing often, looking out for signs, but then being able to maintain the responsiveness to be able to adjust our style and our approach. And then afterwards, then our care planning becoming critical, because we can't simply be there 24/7. So we need to hand over carefully with confidence. And then this layered approach will hopefully help you collect better data, objective and subjective data that helps support this ongoing dynamic approach of postural care that we know is critical. And we'll look at these in a bit more detail shortly. Overarching all of this, of course, is MDT, so this multidisciplinary working, and the topic that we're talking about today, the incredible speech and language therapists who have that expert knowledge and who are key players in promoting communication inclusion. So I just want to recognise, I want to take this opportunity really to recognise the importance of working with others as part of this MDT team, especially speech and language therapists, or SALT, I'll call them to make it simpler. Communication doesn't just sit on the shoulders of any one professional. It's a shared responsibility, and inclusive communication should be embedded not just at the individual level, but also service and system levels as well. So kind of a great quote from the Royal College of Speech and Language Therapists says that inclusive communication is relevant to everyone and to all forms of communication, and should be adopted at individual, organisational and population level. So when speech and language therapists hopefully are involved, they play that vital role in reducing isolation, enabling participation, and ensuring services like postural care are equitable and, of course, legally compliant as well. And of course, the first question we should be asking is if there is a SALT involved, or have they ever been involved, but there are going to be cases for whatever reason that a SALT isn't directly involved. And again, depending on what that reason is that something that you can signpost or refer to? But regardless, as postural care assessors, as therapists, as clinicians, we still have a responsibility to consider interaction styles, to consider the strategies and tools and the environment that will either promote or limit someone's ability to engage with us. So it's not just about what's doing what's easy or routine, but thinking about what's right for that individual. So I would recommend reaching out to a SALT in your area, develop those professional networks, understand what support you do have access to. The Royal College website might be a good place to start with that, to see what support is in your area. But of course, if for some reason we cannot seek that specialist support, it is more important than ever that we invest in the time and effort to understand communication needs. Often when we think of communication, we default to language, but in this context, especially within complex needs, communication is much broader. Maybe the individual has verbal communication, but is limited in kind of the sentence structure. Maybe that's impacted by their intellectual disability. It could be that they have expressive dysphagia. So they have that concern, like post-stroke potentially, where maybe they have the capacity to understand but express in that aphasia is coming across in their expressive language. Maybe they use sign-in or Makaton, utilising picture exchange communication systems like PEX boards, or even eye gaze, just to name kind of a few different strategies that we may come across. And information gathering, as I've said, through the subjective assessment is vital. It should help you navigate that by truly understanding the individual and not making assumptions. I have worked with individuals who giggle when they're in pain. So please do challenge assumptions, be a detective, ask the right questions around communication, and no detail is too small or insignificant. Key information should be found in things like a communication passport, traffic light assessments, or even health action plans. So maybe worth following this up if it isn't available, if you feel it's critical to their support ongoing. And just a quick tip really to reiterate that it's especially important to recognise how someone communicates pain or discomfort, how they would demonstrate being content or comfortable before we get hands-on with the objective assessment. When a person has cognitive difficulties, neurodiversity or acquired impairments, through stroke rehab potentially, then on top of communication challenges, we can see multiple layers that influence their engagement, things like sensory processing differences, hypersensitivity to different touch and sensations, slower processing or fatiguing quickly. The psychological impacts around things like anxiety and unpredictability. It could be a need for routine, predictable, familiar cues, and all these factors will affect how someone tolerates tasks and demands that we put on them during our assessment process, and how they interact with us, but also the environment. So anticipating them is essential if you are working with individuals who may have these cognitive or neurodiverse profiles, because that could actually even determine the strategies and equipment that we put in place when we think of things like aesthetics and colours and tactility. So again, this might be an area of further learning that you needed to really understand these unique barriers that they may be facing. Just quickly make you aware of the legal framework, as it is essential that those who work with individuals with complex disabilities know and follow the principles of relevant legislation, because that's what's critical for protecting their welfare, especially for adults who are unable to make decisions for themselves. But it's also a framework to protect us as well. As we know, kind of the law states that we should be supporting individuals as much as possible to make their own decision before it's concluded that they lack capacity to make that decision. So again, not making assumptions, breaking it down into these small decisions. If there is a lack of capacity, if it's deemed, in a MDT setting for that specific decision, then of course the action must always be in their best interest. And I just wanted to really highlight that something like the MCA, the Mental Capacity Act toolkit, may be a benefit for you, because that can sometimes help guide you through that process if you're new to this and you're concerned about things like cognition and capacity to understand and consent to interventions. And there's also the Equality Act as well, which is a major piece of legislation that of course makes it illegal for us to discriminate against someone on the grounds of disability. But what's helpful is that it gives us additional powers to be able to make things like reasonable adjustments to support someone to engage effectively, so we can have that support within our service provision. When we talk about reasonable adjustments, this is kind of a helpful structured process to take you through that flow and navigate it. So first we kind of understand the individual and the support network's needs to make sure the adjustments, of course, are specific to them. By doing that, we can identify potential barriers. What is going to make the assessment or intervention difficult for them? We can then brainstorm solutions, explore various adjustments, and these could just be simple changes to potentially the format of a letter or a correspondence that goes out beforehand, to more complex ones like changing the setting, being able to give a longer appointment time, for example. We then consider what is reasonable, because of course it has to be practical as well. We can then implement that, whatever these kind of agreed adjustments are, but we still need to regularly check them to make sure they are working, and no further adjustments are needed. And then just be aware as well, especially if you're kind of in mainstream generic services, that if you are struggling to provide the required adjustments, then is it time to consider escalating and referring to a specialist service? And again, that's how it works in your different areas, what the particular diagnosis or input might be, but that might be worth investing in some time to find out what the next steps would be. So here are some examples and reasonable adjustments you may need to consider and employ. So first of all, thinking about the accessibility, so the physical space, making sure it's safe, thinking about the entry and exit points, steps, ramps, doorways, and so on, ensuring that moving and handling equipment is available, because that's going to be important for the objective assessment. And then the environment itself, does it need to be familiar to the individual? Can we reduce noise or control the lighting where possible? Do we need to limit distractions, thinking about who's present? Because some people may react quite negatively if there's too many faces or bodies around. Do we need to think about having a trusted caregiver or support present? Sometimes familiar items or props can just help with that acclimatization. We might need to allow time for orientation as well. I've worked with individuals where we've tried to employ aquatic therapy, so hydrotherapy programs, knowing that the first 6 sessions just involves them walking around the outside of the pool before even getting in the water. And again, trying to find ways to implement that into your service provision. Thinking about then the timing, so breaking into shorter segments potentially, scheduling when the person's at their best, where we can get a better understanding of the limitations of their physical presentation, providing longer appointment times, and then of course the communication support that comes with that, being able to adapt to the level of cognition, to use visual aids potentially or choice boards, being aware of our own gestures and our cues, and especially allowing more time for processing information as well, pausing and allowing that feedback. That also applies as well as communication before we meet the person, you know, correspondence, as I said, in different formats. You may also need to consider interpreter, so British Sign Language or potentially different foreign language. And I think it's important to just accept that these aren't just nice extras. They are often essential to getting valid data and protecting that therapeutic relationship. So when we do then meet with the person after all that planning, it's vital that we're not just looking at the person, but we're engaging with them. So every movement, every expression, even the lack of response in itself can be a cue, not just to their comfort, but their preference or their tolerance. If you're only waiting for verbal responses or only focusing on physical presentation, you will miss those layered signals that can really transform your understanding. So look out for non-verbal cues, things like shifting or guarding, subtle changes to body tension potentially, tone and reflexes changing, even facial expressions, the changing gaze, eye aversion, changes to behaviour or their mannerisms, their request to change position, if they're pushing things away or throwing things away. being able to attempt to reach or manipulate the environment, to remove themselves from it. Those missed cues will result in missed clinical opportunities. And again, it's about being this detective, gathering as much information as possible, because I promise you that will make your postural care strategies much more effective, and will actually in the long run hopefully reduce complexity and reduce intensity, because we're being proactive and we're getting it right at the first time before really significant complications set in. Remember, the communication is two-way. It's not just about what the person can or can't say or do. It's about how we tune in and respond to that as well. So the success of a seating or a postural assessment depends not on their ability to engage, but our ability to match their style as well, and to be able to listen to that. So that might mean slowing our speech, reducing our body language, appearing calmer, giving them more space, observing more. In some cases, you might actually need to be a bit more playful or animated, especially if you're working with within paediatrics or potentially within learning disabilities where there's a global development delay. The key is being flexible and attuned, because that two-way interaction is what forms the foundation for everything that follows within our therapeutic relationship. Small things, simply like sitting rather than standing, pacing our approach, being at eye level, giving control or choice, can signal our respect and safety. And evidence actually suggests that our posture influences their perception as well of that communication to help build that rapport. If that rapport breaks down, our understanding of the person's postural health will be skewed, because the person may be anxious, may be disinclined to engage, they may be reacting to discomfort. We're not truly understanding what the body's limitations are and what we can really achieve with our strategies. So remember, it's an interactive process. It's about noticing, about responding, mirroring back to that person, the pace, the energy and the tension, because that's what will either build trust or it will create distance. Just wanted to take a quick pause to reflect, really, to put ourselves in the place of the patient, of the client, of the customer, and think about a time when someone communicated poorly with you, whether that was in your own health appointment, in the supermarket, in the shop, maybe it was with a friend or a family member, maybe they rushed, didn't listen, used too much jargon or ignored your perspective, and just think about how that made you feel. Were you overwhelmed? Did it make you anxious? Did you feel disrespected? Did you just switch off completely? And think about what you needed from them in that moment. And that's what many of the people we support experience during those assessments. There's a lot of demands sometimes put on them, especially if they have these barriers. So that feeling, just remember, we never want to unknowingly create that for the people that we're supposed to be helping. So it's a good reflective practice to kind of bring yourself back to, if maybe you are doing an assessment and you can feel yourself becoming frustrated at yourself or losing confidence, just reflect back to actually how you would feel in that instance and how what you do has a major impact on other people. So after all the assessments, the reasoning, the adjustments, the decision making, how do we actually put this into practice? And that's where a care plan becomes critical. As therapists, we just can't be there 24/7. We are not the ones positioning the person every morning. We're not the ones who will notice subtle changes in posture or managing their behaviours that might indicate discomfort. But the care plan that's what's consistently there. It's that bridge between what we provide and what actually happens. So it needs to clearly communicate why it's been chosen, what the signs to look out for that might indicate a problem, who to contact if something changes or goes wrong. And when that's written well and shared meaningfully, the care plan empowers the support team, the caregivers, the family members. It gives them confidence and consistency to protect the individual from deterioration, which in turn protects our caseloads as well. As I said, trying to reduce that complexity, intensity, and re-referrals back in as well. So it's important that we make sure that that time and effort that we've put into the assessment is carried then through into daily life. We can do that by making it accessible. So this is in itself, we need to think about the support network as well as the individual in terms of how we need to make it accessible for them, using accessible language, avoiding jargon that might be hard to understand, adjusting the communication style or format, even utilising images or timetables which may be easier to follow, using bigger text potentially so it stands out, so it's clear, but also that they know that there's ongoing support with clear contact should they need to reach out and re-refer or seek that support again. We can fall into common pitfalls when it comes to engaging with individuals, especially those with complex needs, especially within the world of postural care, and especially talking as a physio as well, where you know, we want to make sure we're not prioritising ideal. I got this in speech bubbles. There's no such thing really as there is a perfect posture, but prioritising this unrealistic gold standard over comfort and engagement, rushing assessments without watching for cues, especially if we you know, are battling with our own issues, our own resources and funding and time constraints. But I promise you, investing in that time will hopefully help you with caseload management. Ignoring non-verbal feedback, thinking that they can't communicate, where actually it's just they have a different way of communicating, and then trying to apply generic solutions as well, without thinking of personalised care, without thinking of individualisation. So always pause, reflect and adapt, and then of course document that so that it can be carried through into daily life. So just to kind of bring all that together, then give you some tips and practical strategies that hopefully you can leave here straight away and implement. So first of all, find out if a speech and language therapist is involved or has ever been involved. Does the individual have a communication passport or traffic light or health action plan that can help guide and navigate that for you? What are the usual communication strategies? Involve the caregivers, the familiar caregivers, trusted caregivers to support interpretation and engagement. Consider reasonable adjustments, as we kind of covered in those planning stages as part of the subjective assessment. Find a good place to communicate in. So just think about where those assessments are taking place. Maybe somewhere without distraction, or actually maybe you do need distractions to try and relieve anxieties and to help with focus. Watch the person, be observant, be flexible. They may tell you things by their body language and facial expressions that might otherwise not be obvious. Use gestures and facial expressions yourself. So if you're asking if someone is happy or unhappy, make your facial expression clear to reinforce what you were saying. You may need to use an object or reference, like a familiar item, early in the session to help orientate that person, so they have that affinity with something, just to try and ground that process. We can trial simple binary choices, you know, this pad or that pad, or closed questions where it's yes, no, simple choices, but just be mindful that you may need to use open-ended questions to encourage conversation with some people. Think about trialing solutions or interventions outside of that formal assessment, because that might make them more relaxed, but just make sure you monitor that well with forms and touch points and review processes. Check with the person that you understand what they are saying. So, you know, this cushion feels too hard. Is that right? So if you think you've understood what that communication is, ask it back to them and see whether you get a response to that. If the person wants to take you to or show you something, go with them. Use that as a really key opportunity to engage and communicate. Try drawing or using technology, so images or videos may be that communication bridge that's needed. But just be aware that some people actually find it easier to use real objects to communicate. So you may need, you know, kind of model or toys to help to demonstrate some things. Take your time, don't rush communication, and just remember that all communication is meaningful. You just might need to work a bit harder to understand that. So let's just finish with just a quick real life example that really highlights what we've been talking about, consolidate that theory into practical So we were asked to review the seating for a man in his late 30s. He lived in supported accommodation after sadly experiencing a brain injury. The referral described kind of changes in positioning, increased leaning, and particularly changes in behaviour as well, with agitation in the current seating. And the caregivers were just unsure really how to support him, whether he needed a new piece of equipment. He was non-verbal. The referral, as it often does, comes with very limited background, because he was new to that environment as well. Kind of the caregivers are struggling to interpret that behaviour. They weren't sure if it was sensory or related to the seating. So rather than jumping straight into measurements, we began, of course, with a subjective assessment, creating this clear structure for the session, using visuals and pacing, having a familiar support worker present who was aware of the referral and the issues, regardless of whether they knew the person well or not. They were aware of the new issues that were coming across, and allowed the individual to handle the solutions, using gestures and pointing and the tactile elements to see how you responded to that seating. By tuning into body language and giving breaks, you could see that he consistently resisted one particular lateral, was responding quite negatively to one, pushing away, and then as part of our assessment technique, looking at the objective side, maybe understanding, is it actually too firm, too high, repositioning, adjusting and being responsive, and becoming then visibly relaxed just to the change in position slightly. So it's just really a great reminder that what initially looked like non-compliance was actually communicative discomfort. So without those adjustments, and especially slowing down and trying to work collaboratively, we would have missed what his body was telling us, and potentially gone down the route of an expensive new piece of equipment. Well, all that was needed was these small adjustments, hopefully reducing his stress, and then the support staff being more confident with that as well going forward. So key takeaways then. Inclusive communication is everyone's responsibility, not just the role of speech and language therapists. Communication and engagement goes far beyond speech and language. So we need to understand interaction, which is essential to identifying needs, preferences and tolerances. Postural care is not just physical, it's relational, it's observational and it's responsive always. The risk of body shape distortion increases when communication needs are overlooked or misunderstood. Just remember, the reasonable adjustments are essential, not optional, and that therapeutic relationship is central to those good outcomes. The person's experience of the assessment matters just as much as the outcome, because that's how we build that rapport and have that compliance going forward. So remember to adjust your approach, your style as well, to improve the quality of your clinical decisions and the information that we can gather to make those informed decisions. Use our observational skills of inherently soft skills to guide your clinical reasoning, and remember that small consistent changes in practice straight away from today can lead to more meaningful, sustainable outcomes. There are some really helpful resources as well. We'll share a PDF of this document that may kind of help guide you. Good starting point, of course, is Royal College Speech and Language Therapists, lots of resources in there, but maybe you have a professional network within the CSP, so the Physiotherapy College, but also the Royal College of OT as well, potentially, having a particular professional network or interest groups. You can get that peer support to understand where support may be indicated. And then there's lots of, charitable organisations like MenCap and SEDS. There's also Easy Health as well that provides some accessible health resources that might just help you in your process of communicating and engaging with individuals. Okay. Back on screen. And this is probably a really good opportunity to say as well, because that's a lot of information I know to kind of get through within 30 minutes, 45 minutes. But just to say to keep a lookout in the new year, because we will really want to develop this topic a bit more, and hopefully have a really incredible guest speaker join us. So keep an eye out for that in the new year so we can really expand on this.
thanks to Rebecca for a really insightful presentation. They always are, but today I felt there was a sea of virtual nodding head. I feel as though, as an assessor, I could give up so many anecdotal examples of lack of or missed engagement opportunities and lack of knowledge sharing, the appropriate care not being available. Perhaps nobody's picked up on a key colour favourite. Just so many different examples, really.
It could be really small things that seem quite insignificant, but for that person, it could be the one thing that.
Well, again, it's a cliche I quite often use: the devil's in the detail. It's the smallest little component of the assessment that can make the biggest difference. So, I guess what I'd say as a senior assessor would be to share as much information as possible. Don't take for granted that we don't need it, because that little nugget could make the big difference between success and failure, or slowing down the overall understanding and experience of somebody with special needs.
And the outcomes that we can actually achieve, because that's why we do it, right? We don't just invest this time and effort to not have positive outcomes. So to really be able to get those clinical objectives, we need to get that personalised care. Yeah.
We just finish off. Kiwi, I don't know if you have any questions.
I haven't seen any come through yet. I think everything's been covered.
We're always accessible anyway. It has funny terms, and we talk about accessibility, but we're accessible as well. So if you do have any kind of challenges or barriers, or you just want a bit more signposting potentially, we might have some good contacts that we can share. You just let us know.
Yeah, and just again to remind you that this is just one format of training that we offer. You know, there's virtual packages we can offer as well as face-to-face. So if there's anything that you'd like us to cover in particular, please let us know and we can put something together for you.
Yeah. Thank you very much for joining us.
Thank you, and see you all soon.
Yeah.
Thank you. Bye-bye.
Bye.